everyone, and welcome to Your Health, Your Choice. I am Dr. Roopnarine, and we are coming to you live from our studios at ACTN. On tonight's program, we're going to be discussing some key topics in the field of healthy aging. In studio with me tonight is Dr. Stacy de Gale. Dr. de Gale is a doctor of physiotherapy. Dr. de Gale has offices at a clinic, Back in Motion TT, and that's located in Point Fortin. As usual tonight, our numbers should come up at the bottom of your screens, and we'll do our very best to answer each and every one of your questions during the program. So guys, let's talk about aging healthily, and let's say hello to Dr. Stacy de Gale. Stacy, welcome to the program.
Thank you so much for having me. I hope we have enough time. It's only an hour, but we'll see what we can push through.
All right, Stacy, thanks for coming on.
Of
We've
course.
been discussing this for a while now. I know it's a field that you're very passionate about.
Yes.
And welcome to the program.
Thank you.
All right, so Stacy, you're someone in the field of physiotherapy
Yes.
that a lot of the times you would see the patients, and your work would be a lot of the times at the end when something has happened
Yes.
to the patients, when they have been injured, or they've fallen down, they have hurt themselves.
Yes.
And it's your job in conjunction with the doctors, especially the orthopedic doctors, to sort of bring them back to that pre-fall level as best as you
Yes,
can.
back in motion, yes.
Back in motion, and that's a really apt name of your clinic.
Yes.
So Stacy, I mean, when I was talking to you before the program and we were planning it, you're really passionate about talking
Yes.
about osteoporosis and fall prevention.
Yes.
Right? And I'm glad to have you on because you have a message, and you have a message that you want to push out there to the public about osteoporosis.
Yes.
And so let's just take it straight from the top.
Yes.
I'm going to give you a platform to deliver your message. Can you just firstly tell us what is osteoporosis and why is it so important that we talk about that topic tonight?
So osteoporosis literally means porous bones, literally,
Right.
in Latin and Greek.
Right.
And it refers to where our bones lose their quality, they lose their density, they become fragile. So
Right.
can you imagine the scaffolding of your house, your foundation, becoming brittle? Your house will fall down. Literally, you're building a house on sand.
Right.
And that is what happens when you become osteoporotic, when your bones become porous.
Right.
It lends itself to so many negative things, including pain, disability, loss of independence, loss of function,
Right.
depression, and I am going to say it clearly, and we will talk about it more, death. And it
Okay.
is a serious side effect of osteoporosis.
Right. Right. So how big a problem is osteoporosis in Trinidad? I mean, Trinidad is really poor in this country at keeping statistics,
Yeah.
but you're someone heavily involved in the field. How common is it in your practice, for example?
In my practice, I get patients who have had osteoporosis after a hip fracture.
Right.
And as a result, may have had to have procedures such as a hip replacement because of it, or osteotomy, or
Right.
some sort of procedure to fuse the bones.
Right.
Which is sad because osteoporosis, I couldn't find any literature
Yeah.
in recent times for Trinidad. But the reality is that as we are speaking here,
Yeah.
every 3 seconds,
Yeah.
someone somewhere in the world is suffering from an osteoporotic fracture.
Right.
And I don't want to diminish the impact of any other disease,
Yeah.
but that is actually more than breast cancer, heart disease, and diabetes put together.
Right.
Every 3 seconds for a disease that is highly preventable.
Right.
And so it must be high on our list because it
Yeah.
is a very silent disease.
Yeah.
It is under-recognized, underrated, underdiagnosed, but with massive negative impact that we can prevent and we can treat.
All right, I hear you. So why do people develop osteoporosis? You're saying osteoporosis is sort of porous bones?
Yes.
But how do people develop it? Why do people develop it?
So I think for us to understand a little better, I want to just, if you will permit me,
Of
to
course.
speak about the anatomy of bone itself.
Yeah, go ahead. I think you have
Just for
some
people to
slides there.
understand,
Yeah.
So if we can maybe go to the 3rd slide, and I want to emphasize, and it's a
Okay,
simple
there you go.
picture, and I want to emphasize that bone is living tissue. We
Right.
don't see it, so we think that it is dead. Bone is living tissue. Bone has cells that nourish it.
Mm-hmm.
Bones have a process that a dance, as it were, that happens between osteoclasts and osteoblasts. Osteoblasts are our bone building cells. Osteoclasts are the cells that reabsorb bone. And this dance between these two cells occurs over a 7-year period. So literally, over 7 years, we actually develop a new skeleton every 7 years.
Okay.
But the reality is that most of our bone, 90% of the strength of our bones occurs from birth to our mid-20s.
Okay.
So we have found with research that if you build your children's bone bank from 0 to 20, there is a 50% less chance of them developing osteoporosis as they grow older.
Right.
And so we consider osteoporosis to be a pediatric disease with geriatric manifestations, because we often think of osteoporosis being an old person.
Yes.
Somebody who's bent over.
Yeah.
And yes, we have those clients, but this is a process that starts in childhood.
From youth.
From youth. And this is why it is so important for us to unpack this condition so that we understand the need to manage from before it even happens, from childhood.
Right.
And so if we go to our 5th slide, it gives you a lovely graphical view of how our bones gets more dense, and then around the 20s it kind of hovers a little bit, and then it starts to peter down, because that dance between the osteoblasts, the bone builders, the osteoclasts, the bone reabsorbers, starts to get a little wonky after your 30s. So your bone literally starts to break down after your 30s. However, it is faster in women because, of course, with ladies, we have all sorts of other impacts on our bones, such as estrogen.
All right. So is it that if we focus on osteoporosis in the pediatric age group, that we could prevent some of these problems in the elderly?
By at least 50%.
All right. So what can we do in the pediatric age group to prevent these problems when they get older? What can we do?
So some of these,
what can they do?
What can they do? So some of the preventative measures in children are also the same preventative measures for adults who may be on that path of becoming osteoporotic or who are already osteoporotic.
Right.
One, when last, and I'm asking the public, for those who have children, who have grandchildren, when last have we taken our children outside to run? Our current generation, they don't know about hopscotch. They don't know about playing football. They don't know about climbing a tree. Everything now is the tablet, the iPhone. We have forgotten the necessity of activity. And it is vital that children get at least 60 minutes of intense physical activity a day.
Every day.
Every day. And COVID-19 has made it worse.
Of course.
So we're now starting to get back out there, but people are concerned about exams. But the reality is, and I'm saying this with somebody who used to sing, persons who sing and who are engaged in physical activity do better in exams.
Right, of course.
So, you know, mesh the two, but it is vital. Being physically active, getting sunlight is imperative, and we'll talk about that a little
specifically more. For the pediatric group.
Especially for the pediatric group. And of course, calcium.
In diet.
In diet.
So if I just want to move you along there, right? You gave us some of the interventions in the pediatric age group, right? Just want to push back a little bit and say, what is the risk factors for osteoporosis in the general population?
So as a reminder, osteoporosis is a silent disease. Again, quite often you know you have osteoporosis when an injury happens. So how can we prevent that? How are you going to be aware that you may be on that path before something happens? So there are a few things we need to ask ourselves. Are you 50 and over and had a recent fracture that happened in a kind of funny way, a very simple injury? Do you have at least one, or did you have at least one parent who was diagnosed with osteoporosis?
This is not like trying to help that. This is you're trying to go through the diagnosis of osteoporosis.
And these are some of the risk factors.
That's right. Go on.
We're looking at somebody who has had early menopause for some reason. That is a risk factor. Certain conditions lend themselves to osteoporosis, including rheumatoid arthritis, the assortment of cancers, bowel disease, celiac disease, diabetes, Parkinson's disease, sedentary lifestyle, persons who are chronic smokers. I don't care if it's cigarettes, the herb, vaping, any type of smoking.
Yeah, of course.
Chronic alcohol use. Genetics. We can't do anything for genetics. But at least we have these risk factors that can give us a little red flag and say, listen, maybe I need to look a little closer at myself. And of course, the use of certain medications. A lot of medications for rheumatoid arthritis, a lot of medications for depression and epilepsy lend itself. Yes.
What's the role of diet in osteoporosis?
Oh my Lord, we cannot overstate it again. And there's an irony because there's a similar thread in a lot of your shows.
Not just, sorry to interrupt, not just diet like calcium to improve it, but is it that foods that are bad and contribute to osteoporosis? That might be a hard question to answer.
So I haven't in my research, and as I said, I have dealt with a lot of osteoporotic patients. But what I can say are the foods that boost, for sure, and that help. So again, calcium, we know anything that's calcium rich, and that is not only milk. So for persons who are lactose intolerant, for example, or people like myself who just don't like milk, you can get a rich source of calcium from many foods, including your oily fish, sardines, for example, with the bone in, a lot of your legumes, especially chickpeas.
So I just want to make a comment on that, right? A lot of doctors, especially pediatricians, nowadays, would be. I mean, it's highly debatable how much or what quality of calcium we get from milk, right? From cow's milk, right? I mean, this is up for debate, but the public must be aware of it, right? Because traditionally we kind of brainwashed to think that calcium, milk, and it might not actually be that we get any good quality source of calcium from milk. And I mean, a lot of our local indigenous doctors, our doctors who have trained and worked here in Trinidad, would sometimes, especially pediatricians, would sometimes say that, listen, you know, we've been brainwashed. We feeding our kids cow's milk out of the US or wherever else, and it's not necessarily thinking that we're helping them with calcium. And I remember one or two of the pediatricians saying, listen, you know, look towards bhaji, look towards pak choy, look towards those. We have an abundance of green leafy vegetables in Trinidad.
That's right.
And we should be looking more towards those because those are higher quality calcium, rather than looking towards what other countries might look towards and falling for the propaganda of cereal and cornflakes and milk and stuff as being healthy or being good sources of calcium. Would you agree with that?
I would agree.
Yeah, so us being Trinidadian, me being from San Fernando, you being from Point Fortin, we have loads of vegetables in the market. There's lots of local produce that is reasonably priced, that we should really be pushing or trying our very best to get the population to eat.
And encouraging, you know, this is something that's interesting that you brought up. When I attended Holy Faith Convent in Penal, one of my subjects was agri-science. And at that time, they removed 5 of us from Agri to do AdMats. And, you know, you think that at that time it's good, but we need to get our children back in learning how to grow food. And every home should have at least a little kitchen garden because these things are available to us and for free almost.
So, I agree, totally agree. So we went through some of the risks as well, some of the foods that might help us. But there's special means of diagnosing osteoporosis, right, as far as I understand. Can you tell us how to diagnose it clinically?
So quite often, because I mean, we can't send every client fast scan. So one of the first things we would do is to screen. So there are certain things we look for with screening. One of our screening tools is actually looking at the height of the patient. And quite often in our offices, after measuring a child after puberty, we stop measuring height. But we need to measure our adults because a loss of height of 2 centimeters or more in at least 6 months could be an indicator of osteoporosis. So that's one of our screening tools. Another way to screen is looking at the history of fractures. And if there's a tendency to have even small fractures, but because of very small accidents, nothing that you will expect a fracture to occur.
All right.
There's also something called a fracture assessment tool. It's freely available online.
Right.
My mother is 77 and she's techie, so everybody can get online now. Everybody has a phone or a tablet or a computer, and it's freely available, and you can do your own assessment, and you can carry your results to your doctor. Everything is not up to the doctor. It's a dance between both of you.
Oh, it's teamwork.
Exactly. And that's what is when your management will be better. So you can do this tool and carry your results to your doctor if you're unsure of what it means. And there's one other, it's a special type of ultrasound that you do at the heel. And it's very quick. In 3 minutes, it gives you a good idea as to if you may be on that path of being osteoporotic.
Right, that's an ultrasound at the heel.
It's a special type, and the reason why it's done at the heel, because the bone at the heel is very close to the bone at the hip. Which is where fractures occur very, very readily in somebody who has brittle bone disease.
So another name for osteoporosis is brittle bone disease. So that's great. So we kind of cover a little bit of what's going on, but why is it this? I mean, we gave the patients the theory, we explained why is it important to them. What are you seeing that made you want to discuss this theory with the patients? What are you seeing? What injuries are you seeing? What happens to an osteoporotic patient if they go undiagnosed? So
let me see if we can pull up another picture. Maybe slide 8. Because this is very familiar to
let's bring
persons.
It home.
So this is what we think of when we think of osteoporosis. We think of someone hunched over. And this is a common...
We see that a lot in the community.
Definitely, walking around. And often we are told, well, that's part of getting older. You just have to live with it. That is a no-no. This could be highly prevented. But this is one of the major effects of osteoporosis. And it's not just about the patient bending over. With that loss of height, with that poor posture, you are affecting their breathing, because with that change in posture, your lungs cannot expand. Some patients start to experience shortness of breath. They are more susceptible of developing chest infections. Some people, because again of that change in posture, their digestion is affected. They cannot absorb foods as well as they should. And so the irony is, with somebody with brittle bones, you want them to be able to absorb food.
Of course.
So we'll be between the devil and the deep blue sea. In somebody who can't absorb food because of their posture. They also suffer a lot from constipation, which also leads not only to issues with the bowel, but it leads to back pain as well. And this is some of the effects of osteoporosis. Pain, loss of appetite, difficulty breathing, fractures, and the sequelae of events that happen with fractures at the hip, at the spine, at the wrist, which are the more common areas for a fracture with osteoporosis. So it not only leads to pain, it leads to disability. And we don't look at the cost factor to our family when someone cannot work because of their injury, and or it may be someone elderly who is retired, who is at home.
All right, so I just want to slow you down there.
Sure, of course.
Stacey, because you give real key information, very compactly there, right? and I'm just going to pull it back up there and go to that with the osteoporosis and the weakening of the bones and the change in the spine. They develop other chronic medical conditions.
Definitely.
And so these are not necessarily people who are bedbound or have fallen, but these are just people who have bad bones or brittle bones who are developing chronic medical illnesses because of it. And reducing their quality of life. And then, so that's kind of scary, because we wouldn't say that's serious osteoporosis or bad, but we're just saying that the mild to moderate osteoporosis causes these chronic conditions. And then you went on to tell us something about more moderate to severe osteoporosis, where they might fall and hurt themselves. And then the problems with falling and hurting themselves as well, being bedbound and all that. So what are the common fractures that you see with osteoporosis? What are the common? Because this is the thing, I mean, not everyone that falls is going to break a bone. But you're more at risk of breaking a bone when you fall.
That's right.
Right? So some things break and cause doctors and physiotherapists more problems. What are those bones that you are worried about, that you don't want to see people falling? Why is that? What bones?
Bones in the wrist, particularly the radius and the ulna. But the radius is more susceptible.
Wrist bones.
Wrist bones. Bones at the hip, the head of the femur. And that is what causes a lot of patients now to have surgery. And that is where I am even more fearful of, because 50% of patients who have a fracture at the hip die within 2 years because of the immobility, because of the lack of movement that injury causes. And it's not just a Trinidad thing. This is even in the US, in Europe, in the UK. It is something worldwide. And it is very scary. I get very passionate when patients come to me after a hip fracture. And I have to really emphasize the need for movement as much as is humanly possible, as well as fractures of the spine, especially in the upper back, the thoracic spine. That's where we get most of our fractures with osteoporosis.
Okay, all right. So, Stacey, it's time for a little break.
Okay, good.
And then we'll push on a bit more afterwards.
Yes.
All right, guys. So I'm here with Dr. Stacy de Gale. We're talking about osteoporosis. We're going to move on to falls afterwards, fall prevention. We're going to talk a little bit about other topics in healthy aging. It's a very important topic. Stacy is here to share this message. She's very passionate about the field. She works in the field every day. All right, guys. So I'm Dr. Roopnarine, and we'll be back with you in one moment.
ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. There's nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're here with Dr. Stacy de Gale, and we're talking about osteoporosis, falls, and healthy aging. Stacy, just before we went to the break there, or at the break, you were telling me that you just wanted to discuss a few snap facts on osteoporosis before we push on.
Yes.
Please, go ahead.
So we really want to drill it home.
Yeah.
1 out of every 3 women over the age of 50.
Yeah.
We can pull up this slide. Let's see what slide number this is. So we can have it, so we can cement it in our brains. So osteoporosis fact, slide number 9.
Yeah.
So 1 out of 3 women over the age of 50 will suffer from osteoporosis.
All right, it's up there.
Yeah. 1 out of every 5 men over the age of 50 will suffer from
Can I ask you, is there any kind of racial proportion or anything like that? Or
so,
is it that all of us, no matter what race or whatever, or where we're from,
so
the risk is the same?
Research has shown a higher frequency in Caucasians and Asian heritage.
Okay.
However, that has changed dramatically because of people's lifestyles have changed. We sit more in offices, as well as COVID-19 is definitely going to change that because of the amount of time we spend sitting. But definitely it's seen more in Caucasian and Asian hereditary.
Right.
Every 3 seconds, I said it before, I'm saying it again, there is someone suffering from an osteoporotic fracture somewhere in the world.
Yeah.
And of course, more women are hospitalized due to osteoporosis-related fracture than for breast cancer.
Right.
But yet we are not waving the flag of osteoporosis because it's so silent.
Right.
And 60% of women with an osteoporotic fracture a year later after the fracture still requires some form of assistance. And assistance doesn't only mean the use of a cane or an assistive device, but it means help from a family member, for example. So it is vital that we know these facts and appreciate the impact that osteoporosis can have, and that we must prevent and or treat when diagnosed.
All right. And you wanted to give us a little information on diagnosis as well, if you could go ahead.
So there's a gold standard for diagnosis called the DEXA, DXA, which is a bone mineral density scan. That is the gold standard worldwide. And we have areas in Trinidad that perform these tests. It is very quick, very safe. It's a special type of X-ray.
Is it expensive?
So expense is always related to what that person perceives to be expensive. So it can be a bit, but it is still cheaper than MRIs and stuff like that. But the reality is, MRIs, X-rays cannot diagnose osteoporosis. You can get an idea, but it cannot diagnose it.
So the gold standard is really
correct. And what the International Osteoporosis Federation is recommending, that every man and woman over the age of 65 should have at least one bone mineral density scan done, even if they're not high risk. And of course, if you're high risk or you have suspicious fractures, well, definitely a scan should be done.
All right. What is the medical treatment for osteoporosis? So
medically, the use of certain medications, and there's a wide range. You'll hear the terms bisphosphonates, for example, which we have a lot of in Trinidad. I'm not sure how much of Fosamax is still being used, but you have other drugs like Actonel, Boniva. I'm not advertising any. But medical management from a medication standpoint is one of the hallmark treatments of osteoporosis.
And what do these tablets do to the body, to the bone?
Some people may be asking, but I have been diagnosed with osteoporosis and I've been given calcium. Now, calcium is not the only issue. Remember in the beginning, we spoke about that dance between the osteoblasts and the osteoclasts. So these medications quite often help to improve that balance. They either increase the activity of the bone builders or your osteoblasts, or they slow down the activities of the osteoclasts.
All right, so in a real way, they can slow down osteoporosis.
Correct.
And maybe and strengthen bone.
That's right.
All right, so those are very important medications in a real way. All right, so let's want to move on a little bit, right? Why do old people fall? Why do elderly fall? I mean, it's elderly people are more predisposed to falling.
Correct.
But why? Why do elderly people fall?
So when we consider a fall, we're thinking of a person reaching the ground. And I want to say that slips and trips are considered falls. So it's not only hitting the ground or hitting a lower level, it's slipping and tripping. So some of us may realize, but wait, I'm not old yet and I already slipping and tripping a little extra. So check yourself, because it's a red flag. But some of the reasons why, especially in the elderly population or the more senior, the falls are more apparent because of muscle weakness, poor balance, poor coordination, visual deficits, visual issues, sensory problems, poor sensation in the feet. For example, a lot of chronic diabetics have sensory issues in the feet, and that predisposes them to falling. Previous falls is also a risk factor in falling. So
maybe you might not be able to answer, but why is the elderly have balance problems? Why do they get, I mean, it's a real physiotherapy question. Why is it that people get balance problems? Other than, say, for example, if they had a cerebral or a brain stroke or something that might affect the balance center. But why is it that there's an elderly person who's osteoporotic, why do they have balance problems and they tip over?
So in any age group, balance is dictated by having a certain amount of muscle strength. It is dictated by having a healthy inner ear. It is dictated by having a healthy cerebellum, which is a part of the brain, the lower brain, and it is dictated by having good vision. So there are 4 factors that are directly related to, fall prevention.
That's 4 really important factors that you highlighted there. And I think one that might be a little bit overlooked by people by clinicians as well is vision.
Oh, yes.
People don't really realize how important vision is in terms of your balance and your walking and
if you talk to your
preventing
patients,
falls.
you would realize your patients, if they didn't slip in the kitchen or the bathroom, they would tell you, I fell either very early in the morning on my way to or from the bathroom, or very late at night. Why? Because the lights are off, or it's poorly lit. A corridor is poorly lit.
Right.
And if I would challenge anybody who's listening to us now or who will listen again later to just stand for a minute and stand on one foot.
One foot.
And then close your eyes.
Right.
And within a second and a half, you will start to wobble.
Right.
And you have no known injury at all. Vision plays a major part. I use myself as an example. I had a corneal transplant recently.
Okay.
And that affected my depth perception. So I had to hold on to railings to walk. And other than that, I'm healthy.
Yes.
So vision is so important. And this is why one of the ways to prevent falls is to have your eyes checked. Because quite often when you realize something is wrong with your vision, it's really late. So prevention. Have your eyes checked at least once a year.
All right. So let's say elderly person at home, right, with a family, and the family is the one who tend to contribute a lot to their care.
Yes.
What can the family do to help granny and grandpa not fall? I mean, the doctors be like, all right, make sure grandpa don't fall, and make sure granny don't fall, and then we send them off, right? When they be like, well, grandpa don't go nowhere, don't sit down right there, stay right there, don't move. But I mean, that ain't gonna work.
Correct.
So what are the tips or the tools that you could tell the family here tonight to help them prevent their granny or grandpa from falling down and hurting themselves?
So I'm gonna address that in two main ways. One,
take your time.
Fall-proofing the home.
Fall-proofing your home.
Yes. That's the term we like to use.
All right. So let's start with that first.
So let's start from parking up in your garage and walking into the home. Especially with COVID, so many people are into gardening now. We have to make sure that your pathways, your corridors, your hallways are clear of clutter. That if a spill occurs, that you clean it up one time. Doc, let me ask you. I'm putting you on the spot.
Don't.
How many times? You have no choice.
I don't clean.
Don't tell anybody you said that.
Go ahead.
Imagine you are walking, and it happens to all of us. You walking and you hit your knee on the same chair every day, 7 days a week, and every day, 7 days a week, you're saying, listen, I need to move this chair.
Nah, my wife tells me move the chair.
Move the chair. That's the head of the family for sure.
You keep it to yourself, then move the chair, look at you, fool.
But sometimes we say it, and only when we trip badly or fall over.
So, I mean, you're right. It's all about planning.
That's right.
And risk assessment.
Yes.
And risk assessment is not for professionals only. A risk assessment is for you as an individual.
Correct.
And we do risk assessments all day long, and people don't realize it. People don't realize it. It was a risk assessment coming out into the studio tonight, or from your car, 8 o'clock in the night.
You have to look around.
You make sure the place is well lit. You pull in. You make sure you see Josh waving at you. So there's risk assessments in everything we do, and sometimes the elderly need us as the younger people to do that risk assessment for them on their behalf. And sometimes we could just sit back or ask a relative to come and look at the house and don't just keep quiet, but say, look, highlight it, because things in front of your face, sometimes you miss it.
You miss it. Because nothing happened. So we can leave it. But it is an accident waiting to happen.
Right. So I would start by saying that when we have foolproofing your house, from what I've learned from you is maybe the kids and stuff have to do a real risk assessment. Not just do things randomly to improve it, but do a real risk assessment from the time mommy or daddy wakes up to the time they go to bed. What could cause them to fall?
Correct.
And that's an important thing.
The rugs, the mats that are not sticking well, the skatey tiles in the bathroom and the kitchen, the laptop cord, the cord from the light.
Seems like everywhere in Trinidad has these kind of slippy tiles.
Yes, it's stylish because they're gorgeous. You know, but they're not necessarily.
No, you gotta be real careful with those tiles and stuff like that.
So that is one of the major ways of fall prevention and fall proofing your home and your surroundings. And
real practical tips here: the bathroom is a common area people fall. What adjustments should be made to the bathroom?
So definitely having grab bars. So it's easier for them to hold on to get out of a tub, for example, or get out of the shower. Making sure you have the sticky ducts, I like to call them, within the shower itself. A non-skid and water safe mat just outside of the tub and the sink.
All right.
Very important. Again, proper lighting,
Right.
even in the bathroom.
All right, so that's the kind of foolproof in the house a little
Yes.
bit. Are we
Yes.
missing anything else there?
Not with regard to the proofing. Those
right.
are the major things, because those are the same concepts you would use for every room.
All right, so what other thing that they can do to prevent mommy and daddy from falling down?
So one of the risks for falls is the fear of falling. So you may have a senior in your care who has
Yeah.
fallen before.
Yeah.
And so I have patients who say, we tell her to sit down, we don't want her to move at all.
Yeah.
You're actually making things worse.
Yeah.
So you must have a certain level of fear to prevent something from happening again.
Yeah.
But it is the excessive fear that we have to avoid.
Right.
Because if you fall, you become fearful, you stop moving,
Yeah.
you become isolated, your muscles become weaker, your coordination gets worse, so that when it is time for you to stand, your balance is even worse.
All right.
So this is where you have to get the advice of a professional, a physiotherapist, and or an occupational therapist to prescribe, I'm saying prescribe because every patient is different, to prescribe the appropriate exercise interventions for this patient to get them moving again with less fear.
All right, so you're basically saying that, and this is a real thing that I've noticed in some of my patients as well. Afraid of fall, don't take it too fast. So that fear of falling, now, I mean, it's a real fear, because if you fall, they're going to hurt themselves.
Correct.
So they have become afraid to fall.
Yes.
And you are saying that makes life even worse.
Yes.
All right, and so we have to move away from that fear of falling. So they have to actually do the exercises.
Have to do the work.
Do the work, and
Yes.
Obviously they'll be safe with a physiotherapist.
Yes, correct.
To get it done. We're going to go a little bit more into that, but we have to take a little break again.
course.
All right. So guys, we're taking a little break. I'm here with Dr. de Gale. We're talking about the elderly, physiotherapy, falls, osteoporosis, a bunch of different topics related to the field. I'd just like to formally invite you at this time to send in your questions and or your comments to us here in studio. All right, guys, so we'll be back in one moment.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest.
Welcome to Harvest. We're doing the double again, north and south. This morning we start here in Brazil Village on Bethany Estate with Michael and Jacinta Mill.
You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance.
So Wendy, you're about to show me your bromeliad house.
Yes,
Oh, this is lovely.
this is what our customers refer to as the Mecca for bromeliads.
Explore the many ways to make your harvest right for you.
So our chicken coop is more or less built at a height whereby it's easy for us to go and just remove the wood shavings into our barrow.
Now, you don't plant out your seedlings, you buy the seedlings, right?
We purchase our seedlings.
Here we are on a not quite monocrop site, but we have rows of tomatoes, rows of sweet peppers, and then you have the Milnes polyculturing.
Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture.
Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice. ACTN The Voice, your family-friendly station.
All right, guys, welcome back. We're here with Dr. Stacy de Gale, and we're talking about osteoporosis. Just want to invite you again to send in your questions and your comments to us, and Stacy will address it. All right, so Stacy, the key part of tonight's
Yes.
topic and discussion, loads of grannies and grandpas out there watching. They've fallen down in the past. it has caused a lot of fear in them.
Yes.
They're afraid that if they mobilize too much, they're going to fall again. Not moving because of the fear of falling is causing them to have lots of other health problems. Yes. It's isolated them from the rest of the world.
Yes.
They're not able to interact. They're not able to go down to the mall and move around. So it's caused a lot of problems. Yet, if they do fall down again, it's pure disaster. They could break a hip and they could possibly die. So they're stuck in no man's land.
Yes.
They don't know which way to go.
Yes.
Guide the patients. How can they, what do they need to do now to move to better health? What they need to do? How can they get over that fear and yet move safely to a good level?
So if we could go to slide 31, just to give a snapshot, and I am speaking from a place of being a physiotherapist.
Of course.
Yeah?
Yeah.
And the reality is there's no quick fix.
Yeah.
We live in a society where we like to feel things. We want to be rubbed, we want to be cracked. But the reality is, and nothing is wrong with that,
yeah.
but if we want longevity and we want to live healthy lives,
it's much more than that.
It's much more than that. And we have to be willing to do the work. And part of that work is checking your physiotherapist, who is trained to manage a wide population of patients with comorbidities, meaning you have other underlying conditions, to prescribe. I'm saying that over and over. I tell my patients, I am prescribing exercise to you. It's not if you want to do it or when. You must do X, Y, Z, this amount, this frequency, this intensity, because this is what will help to prevent future falls. This is what is going to strengthen your bones, to prevent osteoporosis, strengthen your muscles, to prevent pain, disability, loss of function, loss of independence, to prevent injury, to prevent death.
All right.
And
sorry, exercise, what you're saying. I mean, traditionally in Trinidad, we have to get rid of that notion that you know, you get old and you park up in the hammock, you're not exercising as much, right? When one thing that shocked me, like maybe about 10 years ago, no, not about 8 years ago, I went to Florida.
Yes.
And as a doctor, the first thing I noticed was that all these older people, much older, like in the 80s and the 70s, exercising, doing weights, doing programs, doing in the pool, and not only doing that, but working.
Correct.
Actually working, you go to the canteen or the diner or whatever. Even in the hospital, as a doctor in the hospital canteen, the people that served us were older people in the 70s. So I think if you want to live good, you have to put that into your head, that way of living. That's something positive that we could take from other parts of the world. What exercises do you recommend for these patients?
So there must be a balance. There must be a combination of weight training. Yes, you can lift weights. An 80-year-old woman going to the grocery is lifting up a grocery bag of at least 10 pounds.
Right.
So if she could go to the grocery and lift up that bag, it means she can lift weights for exercise purpose. So I don't want to hear anybody thinking, oh God, I'm too old. No, it's just knowing how to start and what to do. So there must be a combination of weight
never too
training.
old to start exercise.
Never too old. I actually know of a lady in the US who started a weight training at 75, and now she's competing with people half her age and winning competitions. And just a year of work. And so if we stick to a program of weight training, of balance activities, so for example, you like to dance, why are you not dancing? Put on some Marshall and buy us. I'm from South, so I'm going to say put on some Marshall and dance. If you like to do the tango is excellent actually to improve balance.
Exactly, dancing is about balance and coordination.
That's right.
Right.
I mean, sometimes you go to a party and we say, that person has no coordination. You could tell, but it's so important, it's valuable. Tai Chi is excellent for balance as well. Exercises to improve your coordination, exercises to improve your flexibility. Because as we get younger, you know, we get a little stiff, so we need to do things to improve our flexibility. So it has to be a combination of things.
The other thing is, like, if I ask my patients, the elderly, right, I was like, well, do you do exercise? And most of the time they say, well, more than you, Robin. And I'll be like, all right, fine. But I say, what do you do? And most of them will say, like, I take a walk in the afternoon.
Right.
Is that sufficient exercise? Is that really, I mean, there's a real walk culture in terms of exercise in Trinidad. In other countries, people walk to get around, to get to the job.
Correct.
Right? Is walking alone sufficient for an elderly person? I mean, you're kind of hinting that they should be doing some weightlifting.
Correct.
But to the people out there who are doing walking alone, What do you say to them?
So walking is a good start.
Yeah.
Walking is a good cardiovascular aerobic activity to help improve the function of your heart and your lungs. But if we want to exert a positive change on our muscles and bones, we must do more. Especially if we go back to the concept of brittle bones. For brittle bone disease, for example, you must do weight-bearing exercises. Walking does not improve your bone health. Swimming does not improve your bone health. Cycling does not improve your bone health.
Has to be weight.
Has to be weight-bearing type exercises.
Body weight exercises.
Body weight exercises.
All right, that's real. Not just talking about a topic, that's actually giving people solid, hardcore information, whether they like it or not, and real hardcore tip, and real hardcore advice, and that's what I love about that. So, Stacey,
and some people say they don't have time.
Some people say they don't have time.
But guess what? All we need is 150 minutes a week. I'm not even breaking it down. 150 minutes a week of exercise, which is equivalent to 20 minutes a day or 30 minutes 4 times a week. That's all we need.
All right, so Stacey, we need to get, I know you have a lot more information, but we need to get some viewer feedback.
Yes.
All right, so Josh, could you put up the questions or the comments there first, please? Let's get some feedback from the audience. I have lumbar spinal stenosis as well as severe knee arthritis. What are the risks of having a total knee replacement? Are you able to answer that, Stacey?
I can answer. So this is...
Bear in mind you're not an orthopedic surgeon, but you work alongside the orthopedic surgeon.
And this is right up my alley.
And you see these patients, you become their best friend, really, in their rehabilitation.
Correct.
All right, so answer it from your experience.
This is where you have to ask yourself as a patient, what do I want? Can I live with the severe pain that may be the reason why your doctor is recommending that you have a knee replacement because of severe arthritis? Can I live with this pain or not? That is where your first question lies. Your second question, you can have lumbar spinal stenosis and still have a knee replacement, and it will not affect either. A patient like this should be under the care of a physio before surgery, so that we strengthen them before, we minimize as much of their pain before, so that when they come out of surgery, they will respond even better to rehab. So this is a patient who needs to have a team approach to management.
Right. So that's a very good answer there, Stacey. They basically telling the patient what they can tolerate and what the outcome they want.
Correct.
So guide their decision. And I would like to also contribute to it's what the orthopedic surgeon is fearful of or not fearful of, that would guide your decision as well, because the orthopedic surgeon might be very fearful of a negative consequence if you don't do surgery. So we don't know about that information, but if all that information is neutral and that you're not at any increased risk of anything bad happening if you don't have surgery, I think Stacey's advice is really viable there. And the role of the physiotherapist nowadays is more than just post-surgery or more than just after you fall down. And athletics is more than after the athlete has been injured. It's all about prevention of these things and assisted recuperation after surgery much more quickly, right?
Correct.
So we call it sometimes prehab, and we call it post-ab, and we call it pre-surgery physiotherapy. So I think that adequately answers the question there. Yeah. So let's get the next question there, Josh. What's the most important piece of advice you would give men and women in their late 40s to help them start aging healthfully? That's an excellent question.
Oh God, especially since I'm in that category now, in the late 40s. It's a man or woman
who sent it in, but it's well, me too, right? So it's an excellent question.
Yes.
So well, Stacey, give us the answer in your opinion.
Keep it short. So one of the first things is a change of attitude and mindset, because we often think that, oh God, we're getting old, we're seeing the gray hairs. You could color that. We could color the hair. But it's the attitude as to how we're going to get into this next decade of our lives. So we need to ban this concept of ageism, that I'm getting older and I cannot do. And you pointed out carefully.
That kept back though. That's an old sort of. Get rid of that thinking.
And we have to. And as you rightly said, you know,
across the board,
across the board.
Not just getting towards elderly, but I mean young people as well. We have to embrace young people now and say that they are old enough or they are skilled enough to do jobs. I mean, in this country, sometimes we ageism towards the young people.
That's right.
Right?
That's right.
And we need to break down that barrier and then break down those barriers and let young people who are well able deal with matters.
Yes.
And let us acknowledge as well that they're older people, just because age doesn't doesn't mean that we put them to the side,
That's
because
right.
they're well able to.
Correct.
And sorry, I took up your time.
No, but that's fantastic.
Yeah, that's
so
what it.
a change in attitude and mindset, number one.
Yeah.
Of course, we must look at the physical part of it. Exercise, the 150 minutes a week is imperative. That is the fountain of youth. We don't like to do the work, but you feel better. It improves your mood. It prevents so many non-communicable diseases, including osteoporosis, diabetes, Parkinson's disease. Changing your attitude to stress is very important. A lot of us are stressed out. COVID-19 brought a lot of that out. And sometimes you can't change the stress. We can't change the sun in the sky overhead at noon. But what can we do? Maybe use an umbrella. It is how we decide to approach it. And stress is such an important factor. And I'm speaking as a physio because that impacts my patients. Stress increases your pain. It slows down your healing. It makes certain conditions worse. So stress management is important. Eating well, eating balanced, everything in moderation. I am of the view that balance is key once you're not using drugs. Everything in moderation. And if you're not sure, see a dietitian to guide you on that pathway of healthy eating.
All right. I just want to rephrase one of the questions a little bit differently. That guy gave us, or that lady, the viewer gave us a really good question there. What are the key indicators for healthy aging in the late 40s? What are the key? I've asked the other mental health professionals who have come on this program the same question. What is it that you see in a patient? You are working with patients. Some get better, some don't get better. Some of them have the same injury. Some go really good, and you're really proud of them. And others, you know, you're hurt and you want things to get better. What is it in those individual patients, other than physical, that is different? What is it? What are the characteristics of a person that helps them heal and get better faster?
Positive mindset, first and foremost.
Positive mindset.
Yes. I have had patients who, because of their injury, for example, they may have had a severe spinal cord injury, who will never walk again. And they can teach my patients who are complaining about pain in their little toe. It is the attitude, embracing the injury, knowing what you can and cannot do, and knowing how to get over. That's one. Two, there is such a need for a support structure. If that support is your family, a friend, patients who do well have a strong support structure. Patients who don't do as well, they come alone, they live alone, they're isolated, they have nobody to share their thoughts with, their fears with, and it really impacts their status, as well as patients who are not eating well, don't heal as well, and they also don't do as well with their rehab.
All right, and sometimes in medicine, in life we say sometimes it's not the destination but the journey. Sometimes people might be over keen to get better fast. And sometimes they just have to embrace that healing is time heals.
Correct. And some people experience it. I tell all my patients, listen, you've been doing well all the time, and one little thing throws them back and they panic. I said the road to recovery is like the road from Point Fortin to San Fernando, full of potholes. But you will always get back on. And challenges. Embrace that, know how to overcome it, and you'll realize, this improvement is just continuing, and you get better and better and better, and you're able to roll better with the punches.
Don't be afraid.
Correct.
Don't be afraid.
Correct.
Josh, you have any more questions there? How much alcohol can someone over 50 safely drink? And does our tolerance change with aging? Stacy, you want to give it a go? More my field?
I think it's my field, but let me just be facetious and say none. But I am a social drinker, so 1 glass of wine, for example, a day is accepted. But the reality is that alcohol kills our osteoblasts. Those are our bone-building cells. They kill them. So that, and smoking as well. So that the more you drink, you're looking at cell death at the bone level. You're looking at poor absorption of calcium. So again, your bones become brittle. And let's not go into the whole alcoholism talk. But you'll be able to give milliliters. But I'm saying moderation, 1 glass, and nothing straight. So I know some people who drink, I'm not going to say the proper word, penchant, and they drink it straight. No, moderation and chaste.
All right. So it's real hard to quantify what is the allowed or what is not the allowed limit, and at what limit you're going to get problems with your body because of drinking alcohol. And as is everything, moderation, right? So once you're not doing it to excess, that's the key part. And as Stacey was saying, alcohol heavy alcohol consumption contributes to osteoporosis. And there was an old saying amongst doctors that you're only alcoholic if you drink more than the doctor, right?
I'm going to use that.
If you drink more than me.
Use it.
So if you drink more than Stacy Viewer, you definitely need to cut back. So let's get the next question there, Josh. How much exercise do people over age 50 really need? Good question. We kind of answered it.
Yes,
Just hammer it home
and
there.
we're going to hammer it home. Really need 150 minutes per week. That is not a lot. That is 20 minutes a day or 30 minutes 4 times a week. And this is if you're doing moderate intensity exercise. If you're doing more high intensity activities, 75 minutes a day is appropriate. And remember, try to have a mix of exercises. So walking is not sufficient. You need to do some form of weight training, balance activity, coordination activity, exercises to improve your flexibility. But a rule of thumb, 150 minutes a week. And research has also shown that 50 hours of consistent exercise in a 6-month period makes an almost permanent positive change in balance, which will minimize the risk of falls, which again equates to 150 minutes of exercise a week.
All right. Stacey, is there any website or any kind of website that you could recommend to our viewers where they could find like that you would kind of endorse that this is a good website where you could get ideas about different types of exercises to do for your age group? Is there anything that you would recommend?
So many.
Because sometimes people go on the internet and they might end up in the wrong website.
Yeah. There's actually a website, the International Federation of Older Persons. It is one of the subgroups of the World Confederation for Physical Therapy, now known as World Physiotherapy, of which I'm a board member. And this is one of our subgroups, and they're representatives from over 90 countries in the world. So it's a website that has information for professionals as well as patients that directs you to good, safe exercises in chairs, standing, on the road, and a really nice link. So look for the International Federation of Older Persons. And that link should come up.
And it gives you specifics about exercises.
Yes, especially to age well.
All right. Josh, have we left any question untouched? Nothing? All right, good. So, Stacey, we've run out of time.
Already. We knew it would go quickly.
It was really enjoyable. We didn't touch all the different fields that we wanted to, but that's all right. We could do it in the future.
That's right.
The main thing is that we put forward the message you wanted to deliver to the public. You did it really well. You did it really pleasantly. You made it fun for me as well as the host, and I'm sure the viewers enjoyed it. The information you put out, the accurate information. So we'll do it again in the future. And I would just like to thank you for coming in studio tonight.
Thank you so much for having me, and thank you for the work that you're doing, because the relationship is not just doctor telling the patient what to do. There's a dance between patient and client, and the patient has to empower themselves, and shows like yours, that's what you're doing. So thank you.
You're very welcome. Thank you very much, actually. All right, guys, so hope you enjoyed it tonight. That's it for us tonight. On behalf of myself, Stacey, Josh in the studio, thank you very much for tuning in tonight, and we will see you again next week. Have a pleasant evening, everyone. God bless. Take care of yourself, and we'll see you again next week. Good night, everyone.